This program is brought to you by Emory University.
Good morning, everybody. We are missing our fearless leader this morning. Dr. Williams is on vacation. But for those of you who I haven't met, my name is Avery Calhoun. I'm one of the fellows in the clinical tract in my first year. And I'm going to be talking today about HIV and the coronaries. We're going to make the argument that it is more than an average risk factor and how it's applicable to the patient population that we see in Atlanta. I have no disclosures. And these are my learning objectives. So we are going to first start with a little bit of historical context. We'll talk about the evolution and burden of HIV-related heart disease in general. And then we'll get more specifically into coronary disease, the underlying pathophysiology, and the differences in morphology that we see in persons living with HIV. We're going to talk about aspects of pharmacologic management, and specifically, I want to try to debunk some of the concern about drug-drug interactions in these patients. And then lastly, we're going to take some time to talk about the indications for primary prevention. So I want to start with a case. This has been de-identified and changed a little bit. I wanted to, this is a kind of conglomeration of a lot of different details from several patients that I've seen in my clinic at Grady. But this is a 47-year-old female. She's African-American and has well-controlled HIV. Her CD4 count is in the 800s with undetectable viral load on Biktarvy. She has a history of Hep C, hypertension, and tobacco use. And she comes to your clinic at the request of her primary care because of palpitations. In terms of her past medical history, a little bit more specifics about her HIV. She was diagnosed in 2019. She presented with esophageal candidiasis and had a CD4 count of 79 at the time. She had a known positive sexual contact in 2018 and was started on Biktarvy during that admission and has subsequently had really excellent adherence with viral load that's been undetectable, and CD4 count is now in the 800s. Her HCV history, she's antibody positive but viral load negative, was never treated, and then has a history of hypertension. No really significant surgical history, no family history that she knows of. And then social history, she smokes a quarter pack a day. She has for the past 10 years. She drinks on average 7 to 8 beers weekly. No drug use, stable housing. She works full time. The only two medications that she takes are Biktarvy, which is a combination of bictegravir, emtricitabine, and tenofovir, and then amlodipine for her blood pressure. On physical exam, so vitals, her blood pressure is a little bit on the elevated side, 142/82, but her vitals are otherwise unremarkable. She's well appearing. Cardiac exam is unremarkable as well. And she has labs from within the past month, including a CBC with differential, CMP mag, thyroid function, all of that's normal. BNP is 24, A1C is 4.2, and then a lipid panel with a total cholesterol of 181, triglycerides of 78, HDL of 79, and an LDL of 90, which by all accounts is pretty unimpressive. So in addition to working up the palpitations, you decide to consider her ASCVD risk, knowing that HIV confers additional risk. Is there anything that we can do at this point to optimize her risk? So this is the question that I want to try to keep in mind as we go through the rest of the talk, and we'll come back to this at the end. So I want to start first with a little bit of historical context and epidemiology. I know a lot of people have lived through this, but for those of us who haven't, I want to talk a little bit about the dates because I think it's helpful in the historical context when we think about the data that we have in this patient population. But all of this kind of began with a case report that was published by the CDC in June of 1981. That described 5 previously healthy young men who had been diagnosed with pneumocystis pneumonia. And subsequently, there was identification of increasing numbers of opportunistic infections and Kaposi sarcoma, and this subsequently became known as what we now know as AIDS. The virus itself was not identified until 1983. It was by several French scientists who are pictured here. They later won the Nobel Prize in 2008. And then it wasn't until 4 years later in 1985 that we had the first commercial test available. Zidovudine was the first ARV. This was approved in 1987 by the FDA. And then later on, there was highly effective combination therapy that was approved in 1996. So again, this is 15 years later. As a result of the combination therapy, we started to see the death rates peak in the mid 1990s. And then I wanted to kind of highlight a couple of major trials in the HIV and infectious disease worlds that are kind of the foundation for how we practice. The first two are SMART and Aspirit. They demonstrated that with continuous ART and viral suppression, patients living with HIV have near normal life expectancy. And then subsequently, there was the START trial, which looked at early initiation of HIV therapy, which previously our practice was to wait until the CD4 count dropped. But this study showed that early initiation reduced mortality compared to delayed. And so this is why we have the current practices that we do, where we initiate patients as soon as they're diagnosed. And so the WHO changed their recommendations for this in 2015. And so flash forward to today, we have 45 million people living with HIV worldwide. I want to just take a second to highlight the fact that 70% of these patients are living in sub-Saharan Africa, whereas not super surprisingly, most of our data is from North America and Europe. And so while today we're going to be focusing on the data that we have, I think it's important just to acknowledge that this doesn't begin to touch the vast majority of the patients who are living with HIV worldwide. In the United States specifically, there are about 1.1 million people living with HIV. There are around 36,000 new infections annually. For the past couple of years, this has actually been going up. And roughly 66% of people in the US have achieved viral suppression. This is a map from a website called AIDSview. And as you can see, not super surprisingly, just like many of our other chronic diseases, there is a huge portion of these patients living in the Southeast, in Georgia specifically. And the rates in Georgia are actually higher than the national average. Our rates of viral suppression are lower than the national average. For those of us who trained at Emory, I think we are, and everybody for that matter, are pretty well aware of this, but Grady has a service called the Specialized Immunology Service that is actually dedicated to people who are admitted for complications related to uncontrolled HIV. And it's a busy and complicated service. So this is obviously still a problem for the patients that we see. So now I want to shift a little bit to talk about the landscape of heart disease in patients who have HIV and how this has changed over the years. So you can see on the bottom is essentially the change in HIV therapy over time. So before we had treatment for HIV, patients were dying relatively rapidly from complications related to the AIDS itself. And what we saw is that a lot of the time, these patients had dilated cardiomyopathies and large pericardial effusions, but they were primarily dying from complications related to the HIV. And as time goes on and we have effective treatment and we've essentially created a chronic illness that we're able to treat, what we see is that the relative risk for heart failure has gone down, but the overall burden of cardiovascular disease has gone up as these patients are living longer, and we're starting to see that they have an increased risk for cardiovascular disease in general. And so this is again to highlight that in the pre-ART era, we were seeing a lot of dilated cardiomyopathy and pericardial effusions. And now with treatment of HIV, what we are seeing is a shift in what kind of cardiovascular disease these patients have. By far and away, the most common is atherosclerotic disease. This includes coronary disease, stroke, peripheral arterial disease. They still have higher rates of heart failure, and predominantly this is actually more of a diastolic heart failure. The systolic heart failure tends to be more of a result of ischemic cardiomyopathy. They have higher rates of pulmonary hypertension, arrhythmias, including AFib and sudden cardiac death, and then higher rates of venous thrombosis as well. So now we're going to shift and focus specifically on atherosclerotic disease and coronary artery disease. And the reason for this is because atherosclerotic disease is the most common cause of HIV-associated heart disease in patients who are taking antiretroviral therapy. It's also the leading cause of mortality in patients living with HIV in the US and Europe. And it's been pretty well established that HIV in general confers a twofold higher risk of cardiovascular disease. So this on the right is a forest plot of the results from a meta-analysis in 2018 that looked at close to 800,000 patients compared to uninfected controls. And in general, what we found was there was a crude rate for incident cardiovascular disease at about 6 per 10,000 person years. And this is similar to what we see with diabetes. For MI specifically, the risk ratio was about 1.79. And you can see here at the top, this is total cardiovascular events, which included myocardial infarction and stroke, and then the breakdown with MI specifically. We know that this risk of myocardial infarction persists even when you adjust for traditional risk factors. This has been done in numerous studies. The largest was in 2015, was a VA cohort study of about 80,000 patients. And this demonstrated that this twofold increased risk persisted even when you adjust for traditional Framingham risk factors and when you adjust for substance use disorders. It also showed that people living with HIV were more likely to have the traditional risk factors. And this includes hypertension, hyperlipidemia, diabetes. They have close to 2 times the tobacco use rates. And then when they have those risk factors, they are also less likely to be optimized. We also know that there are specific features within HIV that confer higher risk. So there was a large meta-analysis of about 8,000 people looking at HIV positivity. And they, not surprisingly, found that the HIV positivity conferred higher risk, but they found that patients with lower CD4 count, higher viral load, and cumulative ART use were associated with an increased risk of MI. This cumulative ART use, we think, is probably a result of just patients having had HIV for a longer period of time. We also know that women have higher risk. So they have about 1.5 to 2-fold higher risk than men with HIV. And this is particularly high in women of childbearing age, so under 40 years old. And the kind of theory behind that is a loss of protective estrogen effects, which we'll get to a little bit later. It's also been well established in the literature that if in patients with co-infections, so including CMV and HCV, but also VZV and HSV, these patients have higher risk. So now we're going to jump into talking a little bit about pathophysiology. What I'll say as kind of a caveat is there's a ton of data looking at this, and we know kind of a lot of little pieces of the puzzle. What we still don't fully understand is a lot of the big picture. And so what I'm going to try to do is highlight the kind of pieces that I think are the most relevant to our practice. But I think it's important to know there's a lot of data that we have. Just the big picture is something that we're missing. So I'm breaking this down, pathophysiology, into 3 kind of pieces. One is the fact that HIV is a disease that confers chronic inflammation and immune dysregulation. This results in endothelial dysfunction, increased platelet reactivity, and coagulopathy, higher rates of traditional risk factors. And then we're gonna talk about side effects of ART and how eventually this is probably going to go away off of our list. So in terms of the chronic inflammation, this has been like incredibly well established in literature that people living with HIV, not super surprisingly, have higher levels of CRP, IL-6, and D-dimer at baseline. The first study that looked at this was a subgroup analysis of one of the big kind of original trials, the SMART participants. And they demonstrated that not only do these patients have higher levels of these inflammatory markers, but that they were independently associated with a risk of cardiovascular disease. And then again, numerous subsequent studies have shown this. Not only do they have elevated levels, but there is an association and correlation between these markers and MACE and all-cause mortality. There was a study that was published in JAMA Cardiology in 2017, and it was interesting. They used FDG PET to look at inflammation in patients living with HIV. They used 74 patients living with HIV compared to 29 controls. And what they found was that there was an increased amount of inflammation in lymph tissue. And this inflammation in the lymph tissue correlated with disease activity, meaning the more active the disease, the more inflammation they saw on PET in the lymph tissue. They also looked at inflammation in arterial wall and the ascending aorta and the carotids. And what they found was that people living with HIV had baseline elevated amounts of inflammation in the arterial wall, but this didn't correlate with disease activity. And you can see that down here compared to their matched controls, patients who were suppressed still had had inflammation in their arterial walls. And so now that we've talked about inflammation, we're going to talk briefly about immune dysregulation in people living with HIV. The reason is there are kind of key things that I want to mention because these things have also been implicated in atherosclerotic disease. One is elevated monocyte activity. So patients living with HIV have increased monocyte activation. And this has been associated in these patients with the higher burden of vulnerable non-calcified plaque. We also know that women living with HIV have higher than baseline rates of immune activation and higher levels of monocyte activity relative to men. And so this is part of the theory behind why women may have higher risk. And we know that monocyte activity in general is implicated in atherogenesis. Kind of two other things that I think are worth mentioning because there's overlap in HIV and coronary artery disease progression. One is that people living with HIV have overexpression of toll-like receptor 2. This can lead to apoptosis of endothelial cells, which can subsequently trigger thrombus formation. And this has also been implicated in plaque erosion as a potential mechanism. And then HIV is also known to induce the formation of what's called neutrophil extracellular traps. And it's essentially a function of the innate immune system where neutrophils release all of their chromatin in an attempt to bind pathogens. And it creates this huge inflammatory response. And so we know that HIV does this, induces these, but this has also been a process that's been implicated in plaque erosion as well. And so when you look up risk of coronary disease in patients living with HIV, the thing that comes up probably the most often is ART-mediated atherosclerosis. And this is a really kind of complicated relationship between antiretroviral therapy and the risk for coronary disease. I've tried to highlight what I think are the most kind of salient features of this, but the bottom line is that withholding or delaying antiretroviral therapy is very clearly never the answer. We have numerous studies that show this, and the big landmark study in the ID world, like we talked about, is the START trial that showed that patients, if you delay initiation of therapy, they have an increased mortality. There are certain classes of medications that have been shown to increase risk of myocardial infarction. The important thing about this is that these medications are ones that we don't commonly use in modern day practice. The two classes that we have seen this in are protease inhibitors. The most common one that we'll see is ritonavir, and then abacavir as well. So one of the reasons why we don't see these used quite as much is for this reason. And so when patients are on these medications or have a history of these medications, it's generally because they have a risk of, they have features of resistance. There have been numerous studies subsequently that have looked at kind of the overall impact of HIV meds on cardiovascular disease risk. And there was a large meta-analysis that looked at 21,000 patients on ART. And what they showed was the only thing that was statistically significant in terms of effect on the kind of the metabolic syndrome was hypertriglyceridemia. There was no other statistically significant effect on the lipid panel, hypertension, glycemic control, or anything like that. So this is just to kind of summarize what we just talked about. So reasons why patients with HIV are at higher risk for atherosclerotic disease, the HIV itself, plus or minus the effects of their antiretroviral therapy, increased frequency of traditional risk factors, and then co-infections if they have them. All of these things lead to chronic inflammation and endothelial dysfunction and atherogenesis, which ultimately lead to higher rates of atherosclerotic disease and MI. So clinically, what does this mean? In terms of plaque morphology, what we know is that patients living with HIV have higher rates of non-calcified plaque with similar rates of calcified plaque. This has been looked at by a lot of different people. The largest was a meta-analysis published in Circulation in 2021. And as you can see here on the left side, they looked at prevalence of calcified plaque, which was similar in both groups, compared to non-calcified plaque was higher in the HIV positive population. Clinically, so the most common clinical manifestation of coronary artery disease in patients living with HIV is by far and away acute coronary syndrome. And then within acute coronary syndrome, STEMI is actually the most common. There's a lot of variability with what the reported rates are, but anywhere up to 70%, depending on the study that you look at. They're not super surprisingly more likely to have atypical symptoms. The coronary anatomy, so there's a lot of kind of variation in the literature, but the overall major themes are they tend to have higher prevalence of proximal lesions. And single vessel disease is the most likely or most common angiographic finding, but they are still more likely than age-matched controls to have multivessel disease. And then there have been several studies looking at IVUS in these patients, and they tend to have higher thrombus burden compared to their age-matched controls. So in terms of how they do compared to patients who are not living with HIV, there's a lot of conflicting data. There's a lot of studies published historically looking at their outcomes in hospital and then rates of in-stent thrombosis and in-stent restenosis. And there's a lot that kind of suggests they may have higher rates, but there are other studies that say that they maybe don't. The largest that I was able to find was a VA registry study that looked at everybody in the VA system who underwent PCI. And they looked at 546 patients living with HIV versus about 56,000 controls. And what they found was that at 5 years, there was no major difference in MACE or repeat vascularization, but there was an increased risk in all-cause mortality. This was evident actually early on, like 3 months after their index event, and it persisted at about 5 years was the duration of the study. And there have been a lot of kind of people commenting about this, but the speculation is in general, this is a higher risk population with a lot of different risk factors. So their outcomes are overall going to be a little bit worse. In terms of CABG outcomes, there's really not a lot of data. There have been smaller studies looking at this that show that they in general do pretty well. And some of these included patients with lower CD4 counts. And so the bottom line is they do okay. They should be treated obviously in the exact same way. So pharmacologic considerations is what we're going to talk about next. And we're going to focus on kind of the specific considerations with respect to their antiretroviral therapy. So from an antiplatelet therapy standpoint in general, our standard practices are safe. Obviously, anytime that you have patients on other medications, you want to think about drug-drug interactions. What I've kind of done personally is memorize. So Biktarvy is probably the most commonly prescribed antiretroviral therapy at this point. And so I memorize what is safe with Biktarvy, and then everything else I try to look up. And Biktarvy can safely be used with any of our P2I12 inhibitors, and it can also be safely used with any of the GB2B3A inhibitors. So with some of the other medications, including the protease inhibitors, there are the potential for drug-drug interactions. So Plavix obviously has numerous possible interactions, as does prasugrel. And specifically ritonavir with prasugrel can actually decrease the effective levels. So it's important if they're on really any regimen to just kind of think about this and be aware of this when we're deciding on what antiplatelet therapy to use. But in general, there are going to be safe options no matter what they are taking from an antiretroviral therapy standpoint. And then in terms of kind of specific data in this patient population, there really isn't a whole lot. There was a recent study that was published in JACC that looked at the overall effect of clopidogrel versus prasugrel versus aspirin, on platelet inhibition. And they found that Plavix had a more potent platelet inhibitor effect, but really there's not much in the way of data specifically in patients living with HIV. And then in terms of secondary prevention with lipid-lowering therapy. So this is kind of where a lot of the concern is with drug-drug interactions and side effects. But again, in general, statin use in patients living with HIV is safe. There have been a lot of studies looking at lipid-lowering effects, and what they found is that statins work and they work well. They've actually been studied specifically in persons living with HIV, looking at plaque burden on cardiac CT, and they've shown that there is a reduction in vulnerable plaque volumes with the use of statins. So it's obviously important that we get these patients on statins, and in general, these medications are safe. And what I thought was interesting is, for the most part, you actually don't really have to dose adjust any of these medicines. I've tried to group it here on the right into categories. Simvastatin and lovastatin in general should not be used, which I don't think many of us are using these anyway, but there are a lot of drug-drug interactions, and in general, they should be avoided. Atorvastatin and rosuvastatin are safe. So atorvastatin tends to have a little bit more in the way of drug-drug interactions compared to Rasuva, but in general, they are both safe. The only two medications that may need some dose adjustment are if the patients are on protease inhibitors, so ritonavir boosted regimen, or cobicistat. And even then, if you use 50% of the dose, so if you're using 40 milligrams of atorvastatin, you're always going to be fine. You're going to be fine. And then pitavastatin and pravastatin are also safe. They have the fewest drug-drug interactions. And then PCSK9 inhibitors are safe. They have also been studied in patients living with HIV. And some studies actually suggesting a pretty significant reduction in LDL, but they're safe to use. And then Zetia hasn't really been specifically studied in patients living with HIV, but is generally safe and has very few drug-drug interactions. And so now we're going to shift gears a little bit and talk specifically about primary prevention. In kind of the way of risk assessment, there are a lot of limitations in how we traditionally assess risk with respect to taking HIV into account. What we know is that atherosclerotic disease is present in very low-risk patients. And so there have been studies looking at this, and even children who are infected with HIV have been shown to have increased carotid intimal media thickness. And so again, suggesting that this process happens very early on. We also know that our traditional methods of ASCVD risk assessment are not good enough in patients living with HIV. There have been studies, and you can see here at the bottom, that look at rates of both calcified and non-calcified plaque by ASCVD risk. And patients living with HIV have high rates of atherosclerotic disease despite low ASCVD risk assessment by our traditional methods. And the last kind of limitation that I want to bring up is that the presence of HIV positivity alone is really not enough to describe their risk. So their diagnosis history, their control history, their ARV history, and co-infection histories are also very important. And then obviously consideration of their concomitant risk factors. So these are all things that our traditional risk assessment methods really don't take into consideration. So our current guidelines don't really give us a whole lot. The ESC guidelines say that lipid-lowering therapy should be considered in HIV patients with dyslipidemia to achieve LDL goals as defined for high-risk subjects. But again, and this is a 2A recommendation, and they give the caveat that patients with HIV and specifically who have dyslipidemia. In the ACC-AHA guidelines, this HIV status is mentioned, but it's mentioned just as kind of a risk-enhancing factor that we should use when we're discussing patients who have traditional intermediate risk in terms of whether to initiate a statin. So this is all very likely going to change as a result of the Reprieve trial, which was published in the New England Journal in August of this past year. And what it was a phase 3 randomized study looking at 7,769 patients living with HIV on antiretroviral therapy with low to intermediate risk for ASCVD and no clinical history of ASCVD. And they were randomized to pitavastatin 4 milligrams versus placebo. This is a moderate intensity statin. And it was chosen because of the very few drug-drug interactions. Their primary endpoint was MACE, and their secondary endpoints were a composite of MACE and all-cause mortality, as well as all of the individual subcomponents of MACE. This is the breakdown of their participants. So a couple of things worth mentioning. This was a global study. Half of the countries that this was done in were low-income countries. The median age was about 50 in both groups. And then again, as you can see down here, so 40% of the patients were Black, 35% of the patients were white. The median ASCVD risk scores in each group were 4.5. And you can see the distribution here, about 30% 0 to 2.5, 30% 2.5 to 5, and 24% 5 to 7.5, with some that were above 7.5. Close to 88% of patients in each of the groups had undetectable viral loads. So they had to be on antiretroviral therapy to be in the study, and close to 88% were suppressed. And what they found, they actually stopped this trial early because the effects on rates in MACE were lower than predicted with respect to how the degree of LDL lowering that the medication had. And so what they showed was there was a 35% reduction in MACE at 5 years. And the median LDL went from about 107 to 74. And you can see here in the forest plot, so they're plotting their first MACE was their primary outcome, and there was a trend toward positivity favoring pitavastatin for their other outcomes as well. So this is a table that looks at the number needed to treat at 5 years for the subgroups that they looked at, categorized by their ASCVD risk score. So the overall number needed to treat for all of these patients was 106. And not super surprisingly, as the ASCVD risk went up, the number needed to treat went down. And so in patients who had a risk over 10%, the number needed to treat, and again, this is at 5 years, was 35. And there was a study that was actually published this past week, I think February 21st, in JAMA Cardiology. This was a kind of pre-planned sub-study of the REPRIEVE population, and they did baseline and follow-up cardiac CTAs before the beginning of the study and then at 24 months. And they looked at the total volume of non-calcified plaque by cardiac CTA. And what they showed, I think the kind of most striking part about this is that 53% of the patients in the treatment group did not have progression or had progression of their plaque volume, whereas 85% of patients in the placebo group had progression of their plaque volume on CT. And this was again just at 2 years. So as a result of this study, the HIV treatment guidelines have actually already changed over the past couple of months. And they now actually specify, so in patients who are age 40 to 75, in patients who have ASCVD risk estimates between 5 and 20%, they recommend at least moderate intensity statin therapy. And then in patients who have ASCVD risk estimates under 5%, they favor initiating at least a moderate intensity statin after discussion with the risk benefit with the patient, obviously, and then taking into consideration their other HIV-related risk factors and traditional risk factors. And this was something that was endorsed by the ACC-AHA, but it was published by it's part of like the HIV treatment guidelines. So in the future, what we expect to see is clarification of our guidelines regarding, and the lipid panel guidelines regarding statin initiation in low and intermediate risk patients living with HIV. And the hope is also that they will include some of the HIV-related risk factors like viral load and number of years with HIV, CD4 count, et cetera, when they are helping us describe patients' risk. There are also ongoing studies looking at the effects of PCSK9 inhibition. There have been some kind of early suggestions that they may have pretty pronounced effects in arterial wall inflammation in persons living with HIV, but this is something that's ongoing. And then one thing that this talk we haven't really covered, and it could be a talk in and of itself, is that continuing to address disparities is going to be of just absolute importance in this group. So we know that despite having higher than average risk, people living with HIV are less likely to be prescribed really any medications, but lipid-lowering therapy specifically, even when it's for secondary prevention. And then when they are prescribed lipid-lowering therapy, they tend to be at suboptimal doses. And a lot of this is suspected to be because of the concern with drug-drug interactions. And then future directions, looking also at the importance of the multidisciplinary team in these groups. So infectious disease, namely pharmacy, and cardiology, obviously, as well. So going back to our case, you work up her palpitations, knowing in the back of your mind that patients with HIV have higher risks of arrhythmias, including atrial fibrillation. But you also calculate her ASCVD risk, and the number that you get is 4.3%. So by traditional risk assessment, relatively low risk. And you, knowing what we know now about the Reprieve study and the HIV treatment guidelines, decide to have a conversation with her about initiating a statin. The things that you would want to specifically take into consideration for her is obviously female sex, her history of hepatitis C infection, and then her concomitant traditional risk factors, including hypertension and the tobacco use. And ultimately, you decide to initiate a moderate intensity statin. And with her being on Biktarvy, you could choose really anything. So atorvastatin, rosuvastatin, or pitavastatin. And so these are my takeaway points. I think in general, what I want to emphasize is that obviously there are higher rates of cardiovascular disease in these patients, despite adjustment for traditional risk factors. They have disproportionate amounts of non-calcified plaque and are more likely to present with acute coronary syndrome. And then a multidisciplinary approach, including infectious disease and pharmacy, should be considered to ensure that you're not missing drug-drug interactions, but also to ensure that you have patients on appropriate medical therapy. And then primary prevention, including statin initiation and low and intermediate risk patients, is going to be of paramount importance in this patient population with such pronounced risk. I want to say thank you to Dr. Kaylin Moran, is one of the infectious disease specialists who she does a lot of research in cardiovascular disease in patients living with HIV. And then Dr. Terry Jacobson, who's one of our lipid specialists at Grady, who helped review my slides. These are my references. And I will stop there and open it up for questions if anybody has any.
That was a very nice presentation, well needed in the clinic. It gets confusing what to prescribe. Question, patients with HIV and hepatitis C, is there an issue when they also have hepatitis C? Does that accelerate atherosclerosis? Any studies on that?
Yeah, thank you, Dr. Niazi. There have been several studies looking at co-infection in general, including patients who have a history of HCV infection, and their rates are higher. So any sort of co-infection, but the two that are most studied in the literature are co-infection with CMV and HCV.
Thank you.
Avery, that was an excellent talk. But as you know, the ACC and the AHA recently developed like the PREVENT calculator, which removes race and now considers social determinants of health, and using zip code as a proxy for looking at ASCVD risk. I know it's pretty early, but I think that will have a role in kind of looking at like ASCVD risk rather than using the traditional risk calculator that tends to sometimes underestimate or in some cases overestimate risk in disadvantaged populations. I wonder what your thoughts were.
Yeah, and that brings up a great point that Dr. Jacobson and I had talked about, that this is something that they're starting to use some in the lipid clinic. And I think it's certainly going to change how we assess patients' risk in general, and obviously means has a lot of implications in the HIV population in general. But I think it's something that we're already using, at least at Grady, in the patient population. And I know my understanding is it doesn't specifically look at HIV positivity, but may be a helpful adjunct when you're assessing the risk in these patients, because they have higher rates of other risk factors and sociodemographic barriers as well.
So I have a comment and a couple of questions. One is that, this is interesting to think about this in light of, is this specific to the HIV virus, or is this sort of more generalizable? And certainly we've seen the increase in atherosclerotic disease post-COVID or in COVID. And so one has to wonder how much analogy will exists with our sort of post-pandemic or ending or waning pandemic, wherever we are now, with COVID, because those patients have sort of a pretty similar story, right, with the inflammatory markers, et cetera. So I had two questions for you, or sort of another comment / question and then question. So, people of my age were training during the start of HIV, and we've followed these patients for a long time, and I'll be honest with you, given that early data about carotid intermedial thickness, I take care of several patients that are living with HIV, and I've just treated them all with intensely with statins to get their age, LDLs below 70. And so I guess, not to be too cynical, but does, developing new risk factor calculations, is that really helpful? Because they're sort of super high risk. We know that. So I treat them like a, sort of smoking diabetic and put them in that category. And then the real question is, and I had to step off for a phone call in the middle. I don't know if you talk too much about hypercoagulability in these patients, and then the potential aspirin debate that goes on with this. Is this a cohort in which primary prevention with aspirin might be considered?
Yeah, so thank you, Dr. Taylor. There are a couple of things so from what Dr. Moran has told me, and Dr. Jacobson, the general practice is right now at IDP is that all patients with HIV, at least over 40, are being started on statins. And while they're not using specific LDL goals per se outside of kind of our usual threshold, is they like to have higher goals, is kind of what they've told me. But the general practice from an ID standpoint at Grady is that all patients with HIV are now being started on statins. And this is something that from their perspective has shifted after this reprieve data came out. And interestingly, with the COVID stuff, so a lot of like the baseline, like the elevated inflammatory markers and things like that are obviously not specific to HIV. And then the kind of specific features of the immune dysregulation in HIV has some overlap with COVID, like the neutrophil extracellular traps are something that COVID is also known to induce. So it's an interesting kind of thought of, is the COVID patient population going to have a similar trajectory? In terms of will new risk factor assessment methods really change things, I think the answer is probably no. And I'm not gonna lie, I completely blanked on what your second question was now that was talking.
Aspirin use
Yes.
primary prevention in this group,
so
special group.
There have been a couple of studies looking at aspirin, so that it's been pretty well established that patients have higher levels of D-dimer and increased thrombotic risk. And there have been like smaller studies with mixed results in terms of aspirin for primary prevention. So my understanding is there are some longer studies going on, but right now we don't have enough data to use aspirin in these patients for primary prevention.
Thanks so much. It was really an excellent talk.
Okay, thank you guys so much for tuning in.
The preceding program is copyrighted by Emory University.